The simplest form of fertility treatment is a treatment called ovulation induction. What it entails is that we stimulate a woman's ovary to produce eggs. We could do this if she is not producing eggs at all. So for instance, a woman who has polycystic ovarian disease and is not having any menstrual cycles and who is not making eggs, by giving her medication, we can get her to produce eggs. We could also do it for women who are already ovulating. And the idea here is to get her to produce more eggs, maybe 2 or very rarely 3. Why would we want a woman who is already making eggs to produce more eggs? The explanation for this is that the majority of human eggs tend to have chromosomal abnormalities. And by increasing the number of eggs that she produces in a cycle, we increase the odds of finding one chromosomally normal egg, which might lead to a healthy pregnancy. We use medicines to try and increase the number of eggs that she is producing. These could be either tablets or injections or a combination of the two. The tablets that we typically use are called either clomiphene citrate or another medicine called letrozole. The injections that we use are called gonadotrophins and are the same hormones that the body is making every month from the pituitary to stimulate the growth of eggs in the ovary. By increasing the dose of the gonadotrophins that we are using, we stimulate egg production in a woman who's not making eggs, or if she's already making eggs, this leads to the production of more eggs. We give these women tablets and injections starting on the 2nd day of the menstrual cycle, and then we call her in on the 9th or 10th day of the cycle to monitor how the ovary is responding to these medications. For the monitoring, we use internal ultrasound scanning and visualize both the ovaries to see how the egg, or rather the follicle development, is going on. A follicle is a little bag of water which grows through the menstrual cycle till it's ready to release its egg. And usually at this point the follicle reaches a diameter of about 20 to 22 millimeters. It then ruptures and releases the egg. By doing the ultrasound scanning, we can see how the follicle is growing and when it is ready to release its egg. Once it has reached the appropriate size of about 18 to 20 millimeters, we can trigger the release of egg by using another hormone called HCG. At the time of the ultrasound scanning, we monitor not only the growth of the follicle and the size of the follicle, but also we measure the endometrial thickness. The endometrium is the lining of the uterus. When a gardener wants to grow a healthy plant, he needs a good seed and he needs good soil. The same thing applies in conception. So you need a good egg which will lead to a good embryo, and you also need a healthy endometrium which has grown appropriately so that it can receive the embryo. For this reason, we also need to monitor the lining of the uterus called the endometrium. So during the scans, we measure the follicles and the thickness of the endometrium, and when both are appropriate, we trigger the release of the egg by using an injection called HCG. This is typically given late in the evening, and egg release happens 36 hours later. When the egg is being released, we could do one of two things. Either the couple can have normal intercourse, and this process is then called ovulation induction. Or if we want to increase the chances of pregnancy, we can combine the ovulation induction with another procedure called artificial insemination or intrauterine insemination. For this, we ask the gentleman to give us a sample of semen, treat the sample in the laboratory, and retrieve the best swimmers from his semen sample. These sperms are then loaded into a very fine catheter, and this catheter is introduced into the woman's uterus. The good quality sperm are then deposited at the top of the uterus. From here, the sperms swim out into the fallopian tubes, at the end of which the egg is waiting. The egg, which is released from the follicle in the ovary, is picked up by the fallopian tube and stays at the end of the fallopian tube waiting for a sperm to come its way and fertilize it. The artificial insemination gives us better pregnancy rate than just timed natural intercourse combined with ovulation induction. We have almost double the pregnancy rates with intrauterine insemination or artificial insemination. And the reason for this is probably that we have chosen the best sperms and put them at the right place at the right time, and this maximizes the chances of fertilization and conception.